our speakers, chairs, and the audiences to this another episode of ACNS webinars. Welcome to this very informative lecture series for you. The speaker for the first session of today is our honored guest from India, Professor Virendra Dev Sinha. Professor Sinha is a senior consultant neurosurgeon at the Savai Mansingh Medical College, Jaipur, India. He has adorned several administrative positions in neurosurgery, including being the current chairman of the ACNS Neurotrauma Committee. He was the past president of the National Skull-Based Society of India, as well as the president of the Neurotrauma Society of India. He was the past chairman of the Neuro Rehabilitation and Reconstructive Neurosurgery Committee of the WFNS. He has also been instrumental in conducting online webinars for the benefit of the young neurosurgeons of the world on behalf of the WFNS. We are extremely honored to have him today at our webinars, and today he'll be sharing his experiences about 3D printing in neurosurgery. The speaker for the second session of today is our honored guest from Japan, who is also a dear friend of mine, Dr. Yasuaki Inoue. Dr. Inoue is the director of Stroke Center and chief of Department of Neurosurgery, Naragoya Hospital, Chiba, Japan. He did his Cerebrovascular and Endovascular fellowship from the Brigham and Women's Hospital, Harvard Medical School, Massachusetts. His research interests are focused upon cerebrovascular surgery, and he is a noted author with several publications in various peer-reviewed journals. He has also been a part of the ACNS delegation in various workshops and conferences conducted in different parts of the world. We are extremely honored to have him today, and today he'll be speaking upon cerebrovascular neurosurgery in the endovascular era. The chair for the first session of today's webinar is our honored guest and senior faculty from Germany, Professor Maximilian Madonne. Professor Madonne was a past professor and chairman of Department of Neurosurgery at the University of Kiel, Germany. He was also the past president of the WFNS Committee on Neuro Rehabilitation and Reconstruction. He is the founder of several important organizations, including the Madonne Family Foundation, which aims to promote neurosurgery and neurosciences for the young neurosurgeons. He is also a member of several international neurosurgery communities. He is a noted author with over 400 articles in various peer-reviewed journals. We are extremely honored to have him today with us to chair the session of our first speaker, Professor Virendra Sinha. The chair for the second session of today is another cerebrovascular expert from Brazil, Dr. Eduardo Vieira. Dr. Vieira is an assistant professor in the Department of Neurosurgery at the Hospital de Restauração Recife, Brazil. His surgical expertise is mainly focused upon cerebrovascular surgery, and we are extremely honored to have him today to chair the session of Dr. Inoue. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and the wonderful audiences to this online platform of ACNS webinars. A very special welcome to our colleagues in China, and we are extremely thankful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Boon Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this virtual podium to our first chair, Professor Maximilian Madonne.
Thank you very much for this kind introduction. And it's my great honor and pleasure to be with you today, this afternoon. In Germany, it's afternoon. In China, it's India, it's evening. So it's a great pleasure to be with you. And thanks for the honor to inviting me to chair this session on reconstructive neurosurgery. When I started becoming a resident or started a residency back 40 years or more than 40 years ago, we did this reconstruction business in a very simple way, having this polymethacrylate to cover bone defects which had been caused by craniectomies. We did it by hand and never really looked very, very nice. And then came the phase that we had these companies getting involved, that we had to send CTs of the patients and of the bone defects to these companies, and 1, 2, 3 weeks later, we got the reconstruction, 3D reconstruction, which we had to fit in there. That's one thing. The other thing is we did very early in the 80s, and my chairman in Kiel, professor in Essen, where I trained over many years, Professor Grote, he did this polymethacrylate as sulfix as implant after having removed the cervical discs, and this worked fine because it was just simple. We injected it and it molded the way it should be. So we have long experience, 40 years or so, with these techniques, and but we saw that there is good improvement. I'm looking very much forward to this talk of Professor Sinha, who I know is a very active, very enthusiastic, and very delicate neurosurgeon. So I'm looking very much forward to his techniques about reconstruction with 3D printing. Please, Virendra, yours.
Okay, thank you, Dr. Maximilian, for kind words. So first, I want to thank Professor Yaku Kato, she is president of ACNS, for inviting me for this very prestigious webinar. And I want to thank you, Dr. Raja, Dr. Liviu Seng, for coordinating this webinar. And I want to give a special thank Dr. Maximilian for chairing this session. My topic of presentation is 3D printing technique in neurosurgery. Before I start my webinar, I want to just name my few of mentors in my life. Professor Kak, he is head of PGI Chandigarh in India, uh, with whom I started my neurosurgery career. Professor Gav from Germany, Greifswald, under whom I did the endoscopic in all the surgeries. And Professor Kano, I cannot forget him. Um, I learned so many techniques from him and other things, how to behave with a patient. And he also taught me how to do fishing in so many occasions. Professor Yaku Kato, I cannot forget, during her training period, I learned so much from her, and she kept us very nice way. Then Professor Dharkar, most of the time I was with him. He's from my place, and with all the techniques, I learned the honesty part. He's very big person and very honest person, so I learned from him. So my topic is 3D printing. What is 3D printing? 3D printing is additive manufacturing, where printing is done layer by layer. And this webinar, there are so many youngsters out there, neurosurgeon, young neurosurgeon. So I will cover the basic part of 3D as well. When we do any technique or start any technique, there are three stages. One is the cognitive stage, other is the practice and feedback stage, and third is autonomous stage. So still we are in the practice and feedback stage of this 3D printing. 3D printing is a emerging technology where making of dimensional solid from the digital files, and I told before, there is a depositing the successive layers of material until the object is created. In layman term, it is a 3D photocopy where any imaginable or shape or object can be formed under this. Everything has undergone evaluation. Human evaluation, this IT sector evaluation, same the 3D technique evaluation. Three stages: one is infancy stage, other is adolescence, third is the prime stage. Infancy stage from 1981 to 1999, where Hideo Kodama from the Nagoya Municipal Industrial Research make the rapid prototypic system of photopolymer and developed 3D model, but he could patent it. Second stage is adolescence, where Thomas Boland makes synthetic scaffold of human bladder, very coated with cells of human patient, and then it was transplanted into the patient, and it did very well. This stage is from 2000 to 2010. Third stage is 2011 till date, where smart robotic arms, bone replacement, newer medical appliances are there. Not only in medical, but in other fields like jewelry, aircraft, and housing, mainly in the China, it is progressing very well. So, in nutshell, the 3D CAT model, the image in form of the steel file, by the slicing software, it goes to the 3D printer, and finally the object is formed. We all know that two-dimensional radiograph images, X-ray, CT, MRI, they are converted into digital 3D files, which allow creation, complex, customized anatomical and medical structures like this. So in 3D printing process, all the DICOM images, they are changed to volumetric rendering images. Then the database is exported in STL segment form, which supported by the 3D printer. After going there, the STL format is further smoothened, refined to enhance efficacy of the image. Now the printing machine works in X, Y, and Z axis to make the final 3D model. So this is again in nutshell. This is the modeling. This is the printing part, and this is the final finished image we get. There are different techniques are there for making the object. There are 4 techniques are there. One is stereolithography, where these laser rays, they fall reflected from the mirror, they fall over the liquid polymer, and it gets solidified. So once it gets solidify one layer, this platform move in Z axis, and other layer is formed, and finally the 3D model is forms. Then is a selective laser sintering, where the liquid part is replaced with the powder. The principle is same. This advantage of this technique is this can create metal, ceramic, and plastic objects. Then this is the machine which we use in our place, fuse deposition modeling, where their filament spools, they are of different color. They are passes through the heated material, then it's extruded to fuse or bond to layer below, and this is platform which move for 3D models. This is the latest thermal inkjet printing, where the non-contact technique is used, thermal, electromagnetic, piezoelectric, and deposit bio and tiny droplets of living cells or biomaterial. So advantage of this machine, this is a promising technology for bioprinting and tissue engineering. So other than medical, there are few of the fields where the 3D technique is used for manufacturing. Now we come use of 3D printing in medical uses. It can be used for the tissue and organ fabrication. It can be used for creation of customized implant and prostheses, which we use. So CT, MRI, and X-ray films, they are transformed and to make the in a still segment form to form the 3D object. Then implants and anatomical model, where 3D printed anatomical models are of great use for training and understanding of minute details and anatomy. Then pharmaceutical research regarding the drug dose, form, delivery, and discovery, microcapsule can be formed through this process. There are few of 3D models. This is by Harvard. They build the blood vessel and they see the effect of various drugs. They are the low-cost prosthetic fingers. This is for the cranioplasty. They are the bone segment implant, pinna, synthetic skin, and few medical equipments. Now, 3D printing in neurosurgery. We all understand that neurosurgery, no retake is allowed, and it is very important to perform a procedure with adequate knowledge and practice. And how it can be done? 3D printing is a very good method which offers a proper planning and chance to practice the procedure of patient on a customized anatomical model outside the body. So first time the 3D printing started in 2007 and in neurosurgery, where developing an implant and reconstruct facial bones of skull defects. And if we see the history in Europe, in Germany, it was used for the cranial and maxillofacial defects. In Switzerland, it was used for intraoperative models, and in different countries for different purposes. In US also, very few states it was used to begin with, and then in Asia, in China, it was used for preoperative planning. In India, I will let you know, and in this Malaysia, it was used for the pre-existing pathology models, and in Japan for different skull-based tumors and rapid prototyping models containing the meshes means cranioplasty. In India, we use for the CV junction, for aneurysm, for tumor, and for cranioplasty. And in our Delhi, we use for the making the vertebra. And in our AIMS Institute, we use for the simulation in neurosurgery. In Bombay, we use for the AV malformation models we make. Then in South, we make in Coimbatore for the cranioplasty. So now we come 3D printing in neurosurgery. Neurosurgery, we know, involves very intricate relationship of minute structure of brain and spine. So 3D relationship of various structure within limited surgical aperture is difficult in neurosurgery. So it will be better if we know what different important structure nearby the pathology. So this is our model which we created. This is a tumor. This is the sinus and veins, and these are different arteries we develop for the tumors. In cerebrovascular subspecialty, surgical planning and modeling, we know we can read or study the 2D computer screen all the anatomy of the aneurysm, but the depth perception is difficult, which can be done with the help of 3D printing models. In AVM, it has been seen that in children, 12% of operating time can be reduced by use of this 3D printing model. And Nimba used this 3D printing to shape the microcatheter for coiling in 10 patients. So he can manage the size of the microcatheter before surgery. And this is an AVM model which we developed in our department. We know that in CVS, in aneurysm surgery, we can make replica of hemodynamics. So we can practice the clipping of aneurysm. Then we know surgical training and simulation purpose. The old traditional experience based on training purpose program is shifted to simulation based training program, which definitely will help better understanding of the pathology, vascular pathology. So 3D technology has enabled us MRI data or CT data to translate into patient specific model depicting association between the tumor, skull, vasculature, and surrounding pathologic brain tissue. So a surgeon can recognize the location and extent of tumor relative to the gyrus and sulci pattern or skull features. So it gives very good approximate idea of the location of different important structure before surgery. Now the DTI we can transform in the models, images. So in our department, we are having this project where the seventh nerve delineation can be done in acoustic tumor, and which is confirmed in our few of our experimental cases, and definitely helped the position of seventh nerve. Then in neuro-oncology, for surgical planning and modeling, surgical training and simulation, which is important. Now we can use this in functional neurosurgery because we can make the replica of the brain, we can put the electrode, and we can make the real cell before the surgery of epilepsy. The centers which use magnetoencephalography for assisting for this epilepsy surgery, the motion problem is very important there. So patient specific head cast can be made by 3D printing. So this motion artifact factor becomes less for better or facilitate the surgery. In spine, for surgical training and simulation, I will let you know in the next slides. ICP monitoring catheter applications can be used with this. We can make the fluid-filled ventricular system, and we can make the different pressure changes, and monitoring and training programs can be done. Then Surgical replica have been created to practice the surgical approaches. So like this, and this is in Indonesia, we are giving the training program for this. Cranioplasty, I think all we do, and this is very important part of the 3D printing. So just I will share experience of our place. We know that this is a technological innovation, and in our department, we use it for craniovertebral junction, cranioplasty, aneurysm, and intracranial tumors. We know the surgery of CV junction has its own challenges, and normal CV junction is so complex, and abnormal anatomy makes it more complex. And we work in very narrow spaces under the vision of C-arm, and screw insertion is done. And usually there is a abnormal anatomy, abnormal course of the vertebral artery, which make the region further complicated. And we work nearby the brainstem, spinal cord, vertebral artery, and we use these sharp instrument and drills. So it will be better if we do this practice of CV junction surgery before operation. So yes, it is possible, and 3D printed customized models is the answer, and which improve the surgical skill and complication during surgery. So this all published our work, and we all the work is already been published in different journal. This is a pre-operative drill for the CV junction. This is a model, and this is the vertebral artery which we have created here, and this is the putting the screws and fixation of the C1, C2 vertebrae. Then just I want to share this patient where the patient presented with AD, and we planned C1, C2 fixation. This is the model, and showing the vertebral artery. Then we planned the CT angiogram. We show that vertebral artery is on right side, just over the crossing over this joint. And same thing we saw observed in the this our model also. So we plan the mobilization of the vertebral artery. This is a small video where this is the dissecting, and this is the vertebral artery. Found it, and as I told, it's just crossing the joint, and we plan to mobilize it, and we could do it, and we could reach the joint, and we could place the graft, and screw fixation was done, and see, good reduction of the AD, and all the screw they are in position. This work also been published. Now we have done the delineation of the vertebral artery in 20 cases over the this model, and we found that in 15 cases it was lateral, in one case it was hypoplastic, in one case it was just over the joint, and 2 cases it was medial to joint. So delineation of this vertebral artery over the joint in our different patient study proved the anomalies of the vertebral artery, and it was correlated by surgery. This is another patient of AD. The X-ray is not very clear, and C2-3 dislocation. So here we plan C1, C2, C3 fixation, and this is the model, and we could do it. And this is the post-operative CT showing all the screw in position, and there is a marked reduction of the AD, and to some extent the reduction also of C2, C3 dislocation. This work we have published. Now we come to the cranioplasty. This is a small video. Patient was operated for decompressive cranectomy for trauma, and we plan to do cranioplasty using 3D technique. Well, so the important step is separating the muscle from the dura, because if we don't separate, it causes hollow in the temporal region. This is the our mold which we get when to initial start with the our this cranioplasty. So this is a methyl pharma which used to make the cranioplasty mold and this implant, and generally it get stick over this mold. So we use bone wax or saline. So when we remove it, it doesn't break. This is all molds which we used when we started this. Now we have removed it. Then refreshing of the edges. This has come out very nicely because it doesn't get stick because we apply the bone wax before. We are making edges fine, and it has been fixed. So this is a pre-op, this is post-op, very good cosmetic outcome of the patient. This is another patient. There is a large defect here, and see, with this technique we make it, and very good fixation, very good approximation, and see the cosmetic outcome, good cosmetic outcome, except this hollow, which is because of the muscle atrophy. This is another patient, operated, the large defect here. This is the implant we are preparing. This is a very good approximation. See, very good approximation and good cosmetic outcome the patient. Nowadays, what we do, we make the cranial defect prints out. So before we fix it with on the patient, we just check it here, which give more approximate precision of approximation. Nowadays, we don't prepare the mold, this implant inside, we get from the company, and which further shorten the time of the surgery. So this is just a small video to show the pre and post of patients. We use the titanium also, but because of the in our country patient cannot afford this cost, so we make this pharma. So we very large defects, very good surgical or cosmetic outcome. Even bilateral, very good. Even in base, difficult situation, very good outcome in the patients. In any age group, we can do it. In adults, very large defect, very good outcome. Even the patient is unconscious or in even in children, we do it with great results. Now come to aneurysms. This patient was admitted with altered consciousness. There was CT showing angiography showing basilar tip aneurysm. This is the DSA. So we plan to clip it, and we make this model. This showing the basilar tip aneurysm and all vessel nearby the all the vessels nearby it, showing very nicely. We clipped the aneurysm and we were having the idea of different vessels nearby it and bony structures, and it helped us. This is another patient of superior cerebral artery aneurysm here, and this is a model showing the aneurysm. We can know the different vessels and bony structures nearby it, and we clipped it and patient improved. Now we come to the tumor. So before we go for the tumor case illustration, just I want to show how the machine works. It is especially for youngster. All the DICOM images, they are converted to STL. Then that tumor data or any data are loaded. Then we are loading skull and arterial data. Once they are loaded, they are merged. Now it is prepared for to print. This is a machine, printing machine. Now this is how it prints, layer by layer, one layer then other layer, and till the object is formed. So this is the model, the tumor, different arteries and bone. We operated this patient. This was a recurrent tumor, recurrence. So the model helps us the position of different arteries, the extent of the tumor, and in relation with the bones. See, we could remove it without injuring or harming the arteries, and total tumor removal was done and patient improved. This is another case of the CP-angle epidermoid going to the middle cranial fossa, and this is a model showing the vessels and bone relationship. This is the surgery. This helped us the shaping the arteries, and we shaped the J-shape incision, and almost we were removing very clearly. We were knowing the anatomic orientation because of 3D model, and total removal is done. This is the post of MRI. This is another patient of the Lemniscus meningioma, and patient presented to us with blurring of vision, and again this is a machine. This is how we make the model. This is form. This is a model showing the tumor relation to the vessels and optic nerve, and this is the surgery. So when we were operating, if I am having complete 3D imagination or orientation of the optic nerve, different vessels, and tumor. This we could remove it total, and there was no injury to any vessel and nerve, and total removal of tumor done. Patient improved. This work also published. So every technique has pros and cons. The advantage of the 3D printing is customization and personalization, and better education and training, so enhanced productivity. Other advantage is complex shape can be produced, so easy to use, and reduce design complexity, which increase cost efficiency. Then other advantage, democratization and collaboration. So person in the remote location can fabricate the object which is inaccessible sometime. So overall, in performing the minimal invasive neurosurgery that is realistic, reliable and reusable and cost effective. Disadvantage also there of this technique, because it's slow, the still expensive, misuse of the technique, and there is a 3D printing will require lot of vision, money, and time. It will take time for a complete maturation. Other disadvantage is 3D printing have already been used for the criminal purposes, for making the illegal guns, gun magazines. So we must make clear-cut guidelines for its use. So in future, just I want to finish that in future, the most advanced 3D printing application that is anticipated in bioprinting of complex organ. Then in living organs, an implant can be made in the OT, and this printing is repairing the external organs such as skin already been existing. And then advancement in robotic and bioprinting of robotic assisted surgery also be integral in the evolution of this technology. And the tumor models we can make of different consistency now, which we are having in our department. So we can do hands-on practice before surgery with different consistencies of the tumor. So this is our plan for our department. We can just will feed the cassette here. Then printer can print our models in our department, so we don't have to rush to the company again and again. So they are the few of our patients which benefited with this technique. Thank you everyone, and this is our dynamic team. There are 2 engineers which work as day and night, and thank you very much everyone. I finished.
Thank you very much, Professor Madonne. You may unmute your mic, please.
Okay, thank you very much for your excellent presentation. It was a great pleasure to hear this holistic approach to 3D printing. I've seen 2 questions on the screen. One is referring what is the cost of cranioplasty implants and other 3D printing in India, and the second question is what's the rate of infection in cranial implants?
Yes.
Maybe you can answer these before other questions are also asked.
Yes, very good question. The cranioplasty cost $150, including the material.
150 or 1,500?
$150 only, including the material, is very cheap. And I think it's very much affordable to low-income countries. And as far as the infection rate is concerned, we do it first case. We always do this cranioplasty case first. Number 2, we always involve senior person for this surgery, because to avoid the small infection problems. So overall, we have done about 70 cases, and in 1 case we had infection. This is
congratulations. Now, when I may add on this question, when I've seen this cut-come technique, or the computer-aided design and manufacturing, companies would say they present this porous material to have a better ingrowth of the bone around, so a better fixation in addition to your things. What is your material? Is this very solid, or is it also, can it also be created in a porous fashion?
No, it is solid material. It is solid material.
And would you ever seen a break? It's breaking like a ceramic?
No, we have not seen any break. In 1 case, after the patient discharged, he had injury and it was broken. So he again presented to us and we replaced it. This was our statistics.
I don't see any further questions, but I would just have another question. Would you, when you talk about teaching, using 3D as teaching models in the teaching model, what is you have different colors in these materials. Would you also have different structure in the material so that you can get a haptic feeling of how stiff this tissue would be if you would remove the go for an aneurysm, remove some part of the tumor or whatever. So
Yeah.
would you get, is it
Yes.
possible to imitate these surgical issues?
Yes. So nowadays in tumor, we have developed a model where tumor consistency is almost same to the what we see during surgery. Almost. So we use other material which is jelly-like for this. So tumor consistency is, that's why I mentioned in my presentation also. Um, this is just as similar to the tumor what we see per operative. So
how do you know how the machine should make a very
yeah,
tough
we
meningioma, or how would you imitate it from the
it
MRI
is
scans or CT or whatever?
yes, it is just we tell the company person, because meningioma is usually solid. This just generally it is not solid, it is gel form. And as far as the color is concerned, we can have three colors, we can give three color to the in the models. But if we require any additional color, we can do the manual.
The color is not the issue, probably
No,
more the
no,
density or the
yeah,
softness of the tissue, I would think.
yes, that is problem. But just approximate density, we just tell the company person. We are this is under process. We are developing this model, and we have developed two teaching model we have with us, and that is very good. That can show the different consistency of the tumor from very solid to semi-solid type.
I've seen reports from the food companies that they in Israel they are 3D printing like scallops or whatever. So meat to make it from vegetarians. Would you also be able to do this with your machine, or do you need another machine and other materials?
I don't understand.
Okay.
Yeah.
What how much does this machine cost, and what materials do you have to add to get all this optimized 3D printing models for your teaching?
This machine we don't have. This is a company machine. They just charge the rent for this machine.
Okay.
We don't have in our department. This is the company machine. They just charge that is very minimal. They
And
just
what materials is it used for when you have this teaching?
Polylipic acid. Polylipic acid. Solid.
Okay.
Yeah.
Any questions from the floor, from the panel?
Yes, we have Professor Mathuria coming here. Professor Mathuria, all yours.
I'm really pleased to see the topic which have been selected and what he has expressed, everything in all the areas. That way, there are few comments is every surgery involves 3D and much more in neurosurgery and much more in the vital areas and the delicate structures we are dealing with. And the thing goes back, say, when maybe about 15 years back, when Professor Sano delivered the first oration talk at our place in PGI Chandigarh in respect of Professor Gulati, I saw him that he will draw the diagram of the aneurysm prior, the 3D, how he is going to see it on the table, and what all vessels he is going to see it close to the aneurysm, and how he is going to put the clip at the time of surgery. And then post-op, again he will draw the diagram and see that did he find the same which he has drawn earlier. So that's what I am telling Dr. Sinha, that the thing is that what we should have is we should formulate these 3Ds in the delicate areas.
Yes.
Subsequently see it on the table, that are these the same as we have drawn it earlier, or is there anything which we thought and it's not there. Then subsequently we make it evidence based by drawing the post-operative thing and see it that. That is one. The other thing is how we can further improve this technology too. And third is that what is the smallest structure like the vessels In AVMs and aneurysms, we can see it, we can draw it on 3D. Like there might be small vessels when you are putting the clip. Will we be able to see those? Will we be able to see the perforators also? Because these will be seen on the DSA. You are putting the DSA on that. Will you be able to see that? Because these are the important things which we are going, like a ACOM aneurysm. You are doing a basilar top aneurysm. You are doing a, say, the carotid ophthalmic aneurysm. You are doing a, I say, a bifurcation aneurysm, anterocoroidal aneurysms. So like this, will you be able to see those small perforators? Then you draw it on that, then see it intra-op and then see it post-op. That is one part you have to see. Another thing is that when you are doing it in your department, you are developing your department. Say the COVID has paralyzed whole world, but it has taught one thing, and that is online teaching. Say it's a small job which you are doing if you are developing a technology in your department. I think all of us should associate, have such courses online and propagate this technology to the most interior part of any country everywhere. That's what is a job we should pledge and take, and we should see that this technology develops. And third and last is, this machine some department should purchase. Why we should be paying the rent to the company? Like we are in a small state in Rajasthan. Similarly, the various states, we purchase one machine, like with Dr. Sinha. So whole state is helped. Why we should be paying it rent to the company? And it will be cheaper. These are the comments. Anything more? And I like to educate myself on this also.
Thank you, sir, for
these are comments from a very wise old neurosurgeon experience, and congratulations. I didn't want to take all the questions because I had similar questions as you had about the perforators, and we had similar experience. Vieira, you would answer? Why don't you make a joint venture with the other neurosurgeons?
Yes. Yes, we will make it. I told that we are planning to put a machine in our department that will print, that I showed in last slide, that circuit. So only the IT part will be done by the engineer outside, but the machine and CD will be in our department. As far as the size of the vessel is concerned, minimal 2 millimeter, not less than 2 millimeter vessel can be delineated on the models. So this is the restriction.
2 millimeter is too large.
Yeah, I know this is too large, but this is under stage. That's why I told in first, right? We are in second stage. We are in the stage of progression. Maybe after some year we will make it. We can make it perforator also. And in CP angle we can delineate the 7th nerve, because the DTI image can be transcript over the model. So 7th nerve.
You should not wait some years. You should make it now.
Yeah. Yes.
And particularly in epidermoid, like the 7th nerve is like a thin. It's like a fiber.
Yes.
Will you be able to see it on 3D? That is something which is important.
Yes, it is possible, because the DTI image will delineate the place, and even a small size can be deleted by DTI images, and that can be replicated on the model.
Dr. Sinha, you applied to the government for purchasing this machine in your department, and we will
get shortly. Okay. We will get it shortly. Right. We are working for this.
Thank you very much.
You can have a dialogue, intra-Indian dialogue. Any further questions from the audience?
I'll take comments from my co-host, Dr. Liubun Singh.
Yeah, thanks.
How much time do we still have left? Sorry.
We'll take one last question and move on.
Okay, go ahead.
Probably I will ask Professor Sinha, what do you think that in the future, because for example, like a complex aneurysm, we still going using tandem clipping, multiple clips. Do you think that in the future, with the 3D reconstruction of the aneurysm, we can create a specific clip for that patient so you don't use multiple clips?
Yes, we can produce the clip. Instead of multiple, we can put a one clip of multi-faceted, multi-surface clip. We can apply before surgery, so we can practice it and put in the surgery after separating the perforator and all.
Right. Thank you.
Yes.
Thank you very much. The possibilities are unlimited, but the
Yeah.
time is very limited.
Mhm.
Thank you everybody for joining.
Eduardo, would you just say?
I just would like to congratulate for the wonderful work. I think it helps very much in teaching and training of residents and young neurosurgeons. I think it's very valuable in this specific situation.
Right. Thank you. Thank you very much, Professor Vieira. With these comments, we'll take the final concluding remarks from Professor Madonne. Please.
Well, we have seen this progress over recent years, and we need these enthusiastic young colleagues like Professor Sinhau to bring these techniques and other technologies further and to the benefit of our patients. And congratulations again, and thanks for letting me share your experience. Thank you very much.
Thank you. Thank you very much. Indeed, it was a very wonderful session. Thank you, Professor Sinha and Professor Maximilian Madonne. Thank you. Thank you very much. May I inform all our viewers that this webinar is broadcasted on YouTube, Zoom, and WeChat channel. And as of now, we have 1,300 people who are watching us live. We are so grateful to Professor Shubin for broadcasting this on the WeChat channel. So we'll move on to the second session, and I would like to hand over this podium to our second chair, Professor Eduardo Vieira.
Well, first of all, I'd like to thank you for the invitation. I'm extremely honored to be here today. The topic of the second presentation is cerebrovascular neurosurgery in the endovascular era. There is no doubt that since the publication of the ISA in 2002, 2005, cerebrovascular neurosurgery has undergone a huge transformation with endovascular treatment, supplanting microsurgical treatment, and in many centers becoming the preferred method of treating cerebral vascular disease such as aneurysm, arterial venous malformation, and also ischemic brain disease. However, in certain cases, open surgery is still necessary, and when it happens, these lesions requiring surgical treatment are usually the most complex ones. So this makes vascular neurosurgery even more challenging in this so-called endovascular era. So today we have Dr. Yusua Kinoe, who has extensive experience in vascular neurosurgery, especially regarding cerebral revascularization procedures. So let's move on to Dr. Inoe's presentation on cerebrovascular neurosurgery in the endovascular era. Please, Dr. Inoe.
Thank you so much, Professor Vieira. I'm going to share my screen. Okay, before starting my talk, I'd like to thank Professor Kato and my friend Roger for allowing me to be here in this great webinar course. It's my extreme pleasure to be here. Thank you. So today I'd like to talk about cerebrovascular neurosurgery in this endovascular era. So basically in the cerebral vascular surgery, we mainly have two options. First is craniotomy and another is endovascular. Like for the aneurysm surgery, we can do clipping or coiling. And of course, for the AVM or dual AVF surgeries, we can resect it or we can embolize it. But for the cavernous hemangioma, we need to remove that, or for the myeloma patients, we want to do biopsies. But on the other hand, for the carotid stenosis, we can do endarterectomy or place a stent. But even for the tumor, before removing the tumor, we can embolize it. So mainly we have a lot of two options for a lot of variety of diseases. But the number of the craniotomy for the aneurysm cases is going down steadily because the number of the endovascular surgery is going up. So like in Japan, 2020, the number of the endovascular surgery exceeded the number of craniotomy, clipping, for the first time in the history in Japan. So now we need to rethink what is the role of craniotomy in cerebral vascular disease. So the most important strong part of cerebral craniotomy is we can do bypass. And of course, for tumor lesions, we can resect it, or we can evacuate the hematoma. But some people may think that in the craniotomy, the clipping might better in terms of the obliteration of the aneurysms compared with the coiling. Or some people may think that if we need to trap the lesion, the clipping might be better because we can trap the lesion in a short segment. But for the last two parts, as you guys know, the evolution of the devices in the endovascular field is very fast, quick. And so for sure, in the near future, these two strong parts of the craniotomy will gone. But for sure, bypass remains here for us open cerebrovascular surgeons because we cannot do any bypass in the endovascular treatment. So we need to rethink what we can do in bypass. So here is my 6 years experience of bypasses. So I did 141 bypasses for these common cerebrovascular lesions. And of course, most of the bypasses were done for Moyamoya patients. So most of the bypasses are STMCA or STA-ACA. But for the aneurysms or dissections, we sometimes have to do common high flow bypass or OA pica or other variety of bypasses. Let's take a quick look over common cerebrovascular lesions. So here is a lady of a Moyamoya case, and she presented with right upper extremity weaknesses. And we diagnosed with Moyamoya disease, so I decided to do bypass. So I placed 2 STA-MCA bypasses and another STA-ACA bypass. And thankfully, after the surgery, she stopped having TIAs. And another common example of bypass is aneurysm surgery. So this gentleman had a ruptured giant fusiform thrombus, giant thrombus aneurysm and the carotid terminus, which ruptured. So I placed an ECA-RA-M2 so-called high flow bypass, and then I trapped the lesion. So this is one of the common examples. And here's another common example. So this patient had a ruptured P2 fusiform aneurysm. Then I placed an STA P2 bypass to trap the lesion. Or if the vertebral artery fusiform aneurysm involves a pica, then we need to do an OA pica bypass to trap the lesion. Or this is a rare example, but this fusiform aneurysm of the vertebral artery didn't involve the pica, but the contralateral pica was hyperplastic, very tiny, and the left pecum was fetal and the right pecum was hyperplastic. So I placed a V3RA V4 high flow bypass to preserve the blood flow of the vertebral artery. So those are the common examples of the bypasses. So now we can say that one of the roles of bypass is revascularization, like for the Moyamoya patients or other ischemic strokes, we can do bypass. Or if we need to trap the aneurysm or dissected lesions, we can do bypass, revascularize the vessel. But today here, I'd like to propose another role of bypass. Today, I would call it highway construction. We may be able to create an access route for endovascular surgery. I'm going to show you one example. This is the case of a basilar tip aneurysm, which was growing up continuously even after multiple attempts of coiling. And she had 3 history of ruptured aneurysms. First was MCA, second was PCOM, and now third was basilar tip. And the basilar tip aneurysm was coiled in another physician in other facility, but which continuously growing up, and he placed coil, but still it is growing up. So she was referred to my place for treatment. So this is the 3D view of the aneurysm. So my first plan was to attack the open the craniotomy to try to clip it. But my initial thought was it is extremely difficult because we have a coil and it has a very wide neck. So it might be very dangerous. So we need to have second option. So my second option was to place a wide stent to coil a lesion, or horizontal stent to coil up the lesion. So in my experience, a horizontal stent is better in terms of supporting the coil mass. So if possible, I wanted to place a horizontal stent instead of wide stent. So I spoke with this lady and about the treatment plan, and she wanted me to try to open it and try to clip it, but I didn't want to do too much to her, like brain stem perforators. So I promised her I wouldn't go too far. And if I couldn't clip it, then I promised her to place a stent somehow to coil it. So this is our first surgery. So most of the cases for the complex aneurysms, I prefer to harvest STS just in case, because anyways, we cut the STS, so harvesting is a good idea. And after the craniotomy, I'm opening a sylvian fissure. So this lady is already on dual antiplatelet therapy, so I didn't want to cause any unnecessary bleeding. So I'm very slow moving, sharply cutting to avoid any unnecessary bleeding. And her sylvian fissure was a little bit tight because of those 3 episodes of ruptured aneurysms, subarachnoid hemorrhages. And now I came to the aneurysm, and here is the coil mass. And I tried to move the aneurysm, but I couldn't because it is tightly attached to the brainstem. And I'm looking for the other side, but I couldn't move the aneurysm because of the tight attachment to the brainstem. So I didn't even try to clip it. And now I'm coming down to the subtemporal space to find a P2 to do a STA P2 bypass. Because at this point, I was thinking that we might be able to place an STA P2 bypass for an access route for a horizontal stent. So STA P2 bypass is usually a very tiny and deep bypass. But after doing a lot of practices, it is not that big deal. And this is the last stitch. So my plan is to place a stent through this graft, through this anastomosis. So every single stitch should be perfect. So I placed 20 stitches all around so that it is perfect. And this is the last stitch. So usually for the deep bypass, I move very slowly so that we don't cause any unnecessary damage to the brain. You can see the patient is on dual antiplatelet, so working space is a little bit bloody. And after declumping, this is IC green video angiography. And of course, the blood flow from the basilar top through the P1, P2, P3 is stronger than the blood flow through the STA, but we can see that it is patent. So after closing up the head, I brought her to the angio suite. And this is an injection through the STA graft, which illuminates the PCA. And I confirmed that the bypass is patent. Now through the bypass, I place a microcatheter through the basilar tip to the P1 of the other side. Then at this point, I place a framing coil a little bit so that while I'm placing a stent, the stent will not herniate into the aneurysm. I mean, the stent will not drop into the aneurysm. So I wanted to use this coil to support the stent. So after placing a little bit of coil, I started to place a stent. So this time I used a Neuroform Atlas stent through from the left P1 through the neck of the aneurysm to the right P1. And now I'm repositioning the coil mass so that this coil will properly support the stent. After repositioning the coil, I resumed opening the stent. Again, this stenting was through the STA-P2 bypass. And seeing that the stent location is good, then now I'm opening the stent. After this part is very normal, like just continues coiling. But coiling after stenting is very, how can I say, we can tightly pack the aneurysm with the coil because of the scaffold of the stent. And interestingly, in this case, while I'm coiling the aneurysm neck, the coil will start to fill up the space of the previous coil mass, a coil mass of the previous coiling. This part was also recanalized, and I was very afraid of this part because this might be caused a subarachnoid hemorrhage. But with the support of the stent, the coil will start to go into that part also. And then I added some more coils. And at this point, the coil will go down to the neck as well. But seeing the lateral view, this part, it has a stent here. And I placed a stent so that it will cover the posterior wall of the aneurysm, because this part might have important perforator going to the brainstem. So I wanted to place a stent in the posterior side instead of the anterior side, so that I don't have to place a coil in this part. After repositioning the coil multiple times, this is a final coiling. And this is a final view. Now there's no filling of the aneurysm with the patent posterior part of the dome of the aneurysm. And if you're interested, the STA graft is still open, which is properly connected to the P2 part of the PCA. So now, in some limited cases, we might be able to create an access route for endovascular surgery by creating a bypass. So I can say that even in this endovascular era, we still need to learn bypass. So today I heard that we have a lot of residents or young neurosurgeons who want to learn basics of bypasses. So I'm gonna go over the basics of bypass. So in order to make a bypass, we need to know how to harvest a donor or a recipient, and then we need to create a good workspace. Then we can just anastomose. So I'm gonna talk quickly about the donor and recipient preparation. So I classified my experiences in terms of donor and the recipients. I only use 3 types of donors: STA, OA, and ROA. Or in terms of recipients, most of the recipients are already there in the operative field when you attack the lesion, but only V3 had to be harvested specially. And this is the STA harvesting. I like to harvest STA from this corner part, starting from this corner part. And after creating a skin incision, using this bipolar electrocautery with an Addison forceps-shaped bipolar, using a very strong coagulation mode in a very short period, we can coagulate and dissect the skin tissue or small vessels. Like this, briefly coagulate the vessels and then dissect it. So I like to use this bipolar with combination with Kamiyama irrigation suction system. because Professor Kamiyama is my mentor. So I use his forceps and also his irrigation suction system. So again, seeing this perforator, we only need to coagulate the vessel like this and then dissect it. So in most of the cases, the patient is on antiplatelet therapy, so we don't want to cause any troublesome bleeding. So how we stop the bleeding or how we avoid the bleeding is very important. And this is a trick. And after harvesting the parietal branch of the SCA, I extend the skin incision anteriorly toward the forehead using a big scalpel blade. And after reflecting a skin flap, I cut down the Gallia aponeurotica. Using the same technique of the bipolar forceps, I disconnect the SCA frontal branch from the skin tissue. So if you find a tiny perforator, you coagulate the perforator very briefly and then dissect it. And this is a final view of the SCA harvesting. And next most common graft is occipital artery. So for the occipital artery harvesting, I like to create skin incision in this L-shaped manner and start with the distal part like here. And I already located the distal part of the occipital artery using Doppler ultrasound. Then using the same technique, like making the skin incision and using the bipolar coagulation technique, I dissect the subcutaneous layer to find occipital artery. And this patient had another good branch, so I try to harvest this branch as well. After getting the distal part of the occipital artery, I'm now reflecting the skin flap using a scalpel blade. And I don't like to use my monopolar Bobby electrocautery system because it may damage a skin layer or a muscular layer or even the occipital artery. So I like to use a scalpel blade and a hemostasis. And at this part, in this part, the occipital artery has a very tortuous course, and then it dives beneath the muscular layer. So we gotta be very careful. And this is the sternocleidomastoid, SCM muscle, which is now elevated laterally, and this is a splenium capitis. And the occipital artery goes beneath the splenium capitis, which is now elevated medially. And this is the longissimus capitis. And then the occipital artery usually goes among the venous structure, so-called occipital artery venous plexus. So we have to open the venous plexus like this after dissecting the occipital artery of the venous structure. Then I pinch with the bipolar and then coagulate it before cutting it. This way, we can avoid unnecessary bleeding from the venous structures to keep the operative field very clean. And this is a digastric muscle, which is now being elevated inferiorly. And this is the last part of the occipital artery harvesting, and we can finish this at this part. But in most of the cerebrovascular cases, it is very useful to expose the V3 segment of the vertebral artery. So I usually continue to expose the suboccipital field. So here we can see the suboccipital triangle, and this is a semispinalis capitis muscle, which is now being elevated medially, and this is a superior oblique muscle. And here is again a suboccipital triangle. And this is a rectus capitis posterior major muscle. Now I'm elevating medially, and here is a rectus capitis posterior minor. Now I can find the dura mater of the foramen magnum. Then we can easily see the V3 segment of the vertebral artery. So let's talk about the V3 harvesting as well. So after seeing the vertebral artery, just seeing the V3 segment is not enough for bypass, because we really need to fully expose the V3 segment, which is usually located among the venous structure again. So we need to open the venous plexus here again, using the same technique by pinching the venous structure and coagulate very briefly and cut it. Then after that, we just need to peel off the venous structure of the V3 segment. And here is a final view of the V3. Yeah, this is a foramen magnum, and this is a V3, and this is a venous structure. Here we can see the dura mater. And this is a final view of the V3 harvesting. So basically, if we know how we harvest SDA, OA, and V3, then we can technically do most of the bypasses. But besides that, we also need to know how we can maintain the workspace bloodless. So here's another technique. So usually, in order to attack the lesion, we need to open fissure or any sulcus or whatever to dig into the cisterns. And instead of using a blunt technique, which may cause bleeding, which requires hemostasis, I highly recommend using this sharp technique, sharp dissecting technique, which does not cause any bleeding at all, even if the patient is on antiplatelet or therapy. So using sharp blades or sharp scissors and sharply dissect the severe fissure or whatever is highly recommended. And then all we have to do now is just anastomose the vessels. And this is a very normal example of a moya-moya patient SCA M4 bypass. So for the tiny vessel anastomosis, I usually like to use this AVM clips, because this normal conventional temporary clip may injure the tiny vessels. After clamping the recipient, I make an arteriotomy after irrigating the lumen. And I like to do simple interrupted sutures, which will allow you to confirm the inside and modify a little bit like that. So I like to do a simple interrupted instead of running continuous sutures. And usually I like to place 2 stitches on the heel side and the toe side of the donor, which we call stay sutures, because these 2 sutures will have these vessels stay here. And these 2 sutures are most important sutures. Now, after the stay sutures, we just need to continue suturing. And we really need to make sure that both the vessel walls are everted to each other. I mean, which doesn't allow any adventitia or other connective tissue go into the orifice of the anastomosis. And after finishing one side, I move on to the other side, doing the same thing, confirming that both the vessels are everted properly, nothing is inside, and then making knots. And we can do this anastomosis by just practicing. We can make a similar operative field in the laboratory, and then we can just practice it. It's not that big deal. And this is our final stitch. I usually place 20 stitches all around, because if we place a lot of stitches, then it will maximize the size of the orifice of the anastomosis. And also you can design how it opens by placing a lot of stitches. After placing a clip on the donor graft, then I open the recipients. So now I went over the basics of the biopsies, but I want to go back to the role of craniotomy. So I went over the role of the craniotomy and the role of bypass. Mainly, the most strong points of craniotomy is we can do a revascularization, along with we can resect or we can evacuate the hematoma. Also, I'd like to propose that we can create an access route in assistance of the endovascular surgery. So this means that we still need to learn basics of bypass and also clippings, of course, along with endovascular surgery. And I also want to emphasize that we young neurosurgeons really have to learn how we coil the aneurysm or how we place a stent, etc. Here's my conclusion. The bypass remains important procedure even in this endovascular era. And we cerebrovascular neurosurgeons need to learn both endovascular technique and bypass or clipping procedures. Thank you.
Thank you very much, my dear friend Yasu. Professor Vieira.
Thank you, Dr. Inoue, for the wonderful presentation. Congratulations.
Thank you.
I also believe that for any surgeon that wants to be to specialize in the field of cerebrovascular neurosurgery today, I think bypass is paramount. It's extremely needed, and you will deal with lots of cases that will require any kind of revascularization procedure for aneurysms, for ischemic disease, moya, and aneurysm dissections as well. So it's very, very important. I have some questions regarding your presentations. First is, what kind of antiplatelet regime do you use? How many days prior to surgery you start the antiplatelet medication, and also for ruptured cases, ruptured aneurysm, if you start prior to surgery or only after surgery?
Thank you for your question. In terms of the antiplatelet therapy for the elective cases, I usually put two agents like aspirin 100 milligrams and clopidogrel Plavix at 75 milligrams at least 1 week before the surgery, and if possible 2 weeks before the surgery. And for the emergency cases, I usually load the antiplatelets like 300 milligrams of aspirin and also 300 milligrams of clopidogrel. So I load up before the surgery.
Okay, and as a hybrid surgeon, what is your opinion regarding paraclinoid and MCA, medial cerebral artery aneurysm? Yes. Do you think it's better for surgery? It's better for endovascular, especially paraclinoid aneurysms? You see this flow diversion nowadays is the preferred treatment. So what do you think about it?
Well, to begin with, for the MCA aneurysms, still I think clipping is better, because for the wide neck aneurysms, it is extremely difficult for the endovascular surgery and the risk is too much higher. And for the paraclinoid segment, well, I'd say endovascular might be better if you can place a good flow diverters. But if you cannot place a flow diverter for any reasons, for the younger patients, then I would say we need to clip it. So we really need to educate the younger generation how we remove the anterior clinoid process and so on.
Yes, I also think it's very important. And let's say a ruptured paraclinoid aneurysm, not big deal, not large or not giant. How do you approach this kind of aneurysm today?
Ruptured paraclinoid aneurysm?
Yeah.
Well, I would clip it.
Okay, so that's my thinking as well. I think MCA aneurysms surgery is still the best treatment. Paraclinoid aneurysms, I think in the young patient below 40 years, I think surgery is a wonderful option. And for all the ruptured paraclinoid aneurysms, I think surgery is the preferred treatment, except for those patients, very, very old patients or with some comorbidity that precludes surgery. But for most cases, I think surgery is still needed. And I think it's very important that residents and young neurosurgeons learn how to perform anterior clinoidectomy, also posterior, but mainly anterior clinoidectomy and dural ring dissection. I think it's very important because these two aneurysms, paraclinoid and MCA aneurysms, are the aneurysms that we deal most nowadays, especially in the post-subarachnoid hemorrhage. So I think these are the two locations when we will remain operating a lot. And you talked a lot about learning bypass, and how do you, what's your advice for young neurosurgeons or residents that want to start practicing bypass? I mean, a laboratory with rats or Celastic tubes. What's your advice for the young neurosurgeons?
For the training, yeah, practicing bypass is very important because it is, I think, one of the most delicate surgeries in neurosurgical field. And I highly recommend that, if possible, I highly recommend that you use the real operative microscope if you can sneak into the OR in the midnight or something. Because that way you can learn how to use the microscope, how you can feel more comfortable using the microscope. And the practice material, I used only the gauze stitches to begin with, and then I used the artificial vessels. And to be honest, I have never used the mice or rats because I don't want to sacrifice animals. But artificial vessels were enough for me. And I practice every night. I sneak into the OR and I bought the artificial vessels, stitch, and it's very cheap. And we don't have to harm any animals. So I recommend artificial vessel.
Yes, that's what I always did. You know, Celastic tubes, artificial vessels, night, OR, microscope. I think it's the best way to learn. You have all the time you want, and you are practice under the microscope. Just two last questions. What about when you harvest a donor vessel? Do you like to use the pressure distension technique, in which you inject saline so the vessel does not there's no vasospasm? Do you do it? If not, do you use papaverine? What do you use to prevent vasospasm, arterial spasms?
Yeah, after harvesting the donor, I inject saline and to dilate that, and I clip that, and also I place some sponge with papaverine over that to prevent a spasm.
And just one last question: as a hybrid surgeon, what's your opinion about arterial venous malformation?
Well, it's a very big question, and in terms of arterial venous malformation, some may say that we don't have to embolize, or some may say we have to embolize, or radiation is better. But in my opinion, well, partial embolization like deep feeder to allow us to do the surgery more comfortably is my answer. Like pre-surgical embolization of deep feeders, and then I like to resect that.
Perfect. That's my opinion. I don't like very much preoperative embolization. I think if you're gonna do it, you have to do it the deep feeder, okay? Because I have operated on some AVMs that were embolized, and they embolized the superficial and surgically very simple to access early on the surgery. And what happens is that the deep feeders, they become very turgid and very difficult to deal. So if it's possible to embolize only the deep feeders, okay, but if it's not possible, it's better to don't do any preoperative embolization. So
Yes,
I'd
I
like
agree.
now for the other panelists for questions.
Thank you. Thank you, my dear friend Yasu. It was wonderful and always a huge fan of your technique. Thank you, Professor Vieira, for this wonderful comments and questions. I'd like to ask Yasu one question about your coiling through the STA branch. It was a stent placement and coiling. After how many days of bypass did you perform that?
Well, it was immediately after the bypass.
On the same day?
Yes.
Oh, that's wonderful. Thank you very much and very innovative. Professor Maximilian wants to say something. Professor Madonne?
I just had a question. How do you, when I did many bypasses, we always had the problem to teach the anesthesiologist to have a nice flat brain surface. Do you have any miracles to teach the anesthesiologists, or do they perform regularly so that you can easily perform your suturing?
Yeah, I initially, well, when I was a young resident, I tried to speak with them, but speaking with them might be more stressful. So I stopped. And so my mentor, Professor Kamiyama, sometimes mentioned that if the brain is dancing, then you can just synchronize with it. So I try to synchronize with the brain.
Right. Professor Mathuria?
Thank you.
Yes. Say bypass, obviously that is a technique and every neurosurgeon must learn. And what I want to tell you is that a neurosurgeon should learn the endovascular thing also. But at the same time, telling this that all the endovascular techniques are to be practiced by neurosurgeons only is not correct. Because according to me, that is, say the neuro is the only specialty in the body which involves the maximum number of specialties to tackle a lesion. At least I can name 10 specialties which are associated with neuro and even more and more. So whether it is practiced by a radiologist trained endovascular person, neurology trained or neurosurgery trained is immaterial for me, because the thing is I am interested in tackling the aneurysm or the AVM the best possible way I can do. So my main aim is to attack the lesion, safeguard the patient without any complication, irrespective of whether it is done by a neurosurgeon or an endovascular person of a radiologist team. I think all will agree with me on that. And bypass is absolutely correct. But what we should do is, the endovascular people have done a lot of innovations, starting from coiling to balloon assisted, then stent assisted, then PCONers, then putting now recently the contour device. But the biggest problem with the endovascular is in the ruptured aneurysm, most of the time they have to give antiplatelets, which becomes a problem. So many a times, if we are anticipating that we have to put a drainage, then we put the drainage prior and then subject the patient to the stent-assisted coiling or the other technology which I have told. There is no doubt that flow diverter is a panacea for the basilar trunk aneurysms. And according to me, the other aneurysms are not, these are possible to be done by the clipping technique. The unfortunate part is that, including me, I'm also a failure in that we did not go above Professor Ghazi Asargil and Dr. Sugita to innovate more on the aneurysm clips. We should try and innovate more aneurysm clips, because the giant aneurysm is a challenge both to the endovascular people as well as the neurosurgeons. Because there is a lot of recanalization, lots of problems. So we should try and see what we can do on that. Similarly, there may be an aneurysm with a calcified shell, the calcified neck, the atheroma at the neck. So these are all things we should try and see that how safely we can do. These are the comments on that, but how we can achieve it. The achieve is we must have a lax brain, so we should have good neuroprotectants, retractor-less surgery, so we are causing the least possible trauma to the brain. Then we should try and request our anesthetist, like rapid ventricular pacing, intraoperative adenosine-induced cardiac arrest. All these things we can do, and with that, and the maximum neuroprotection, with that we cause the least possible neuronal damage and produce the clipping. Then we should try to have the procedure by which intraoperatively we can see the patency of the perforators. We can see that the aneurysm is completely occluded, and to the extent that we do not need the post-op DSA. If all things we achieve, then only we'll be at par with the endovascular techniques, developing the operative clipping techniques for the aneurysms. That's what is my comment. I like to have opinion of others, Dr. Vieira, Dr. Inoy, and all others. Dr. Macmillan, please. I like to educate myself on that.
Yes, Professor Maximilian, we can begin from you.
Well, I don't have to reiterate, that's certainly true. And whoever does something on the brain, he should be as much as expert as possible. And we have to strive to do the best we can do for our patients. That's simple. I would just like to add, I've done many ECIC bypass in the area before the bypass study, some more than 400 or so. And we've been part of this business, but I learned this just by simply learning on animals. And I think it's a different whether you work on an animal with very soft, with bleeding vessels, or whether you work on a plastic tube. That's a difference. And it's when we want to tackle our patients, we have to be as good as by any means possible. And it's better to sacrifice an animal or a couple of animals instead of making damage to a patient. That's my simple comment. Otherwise, I enjoyed very much your lecture, and great congratulations, and you did an excellent job. Thank you very much, and continue. All the best.
Thank you, Professor Sinha.
Yes, Vasika, if you're given choice for any aneurysm, would like to clip or coil? Both can be done. So what will be your choice for any aneurysm which can be coiled or clipped without problem? So what will be your choice for that patient?
Whom do you ask?
Yasu,
yes,
the question is to you.
Yeah, Yasuko, yeah.
Sorry. So yeah. Oh, sorry. What was the question?
The question is for a given aneurysm, which can be both clipped or coiled. What would be your first choice?
Well, I would clip. So to be honest, for the ruptured cases, I still do clipping for all the cases, because we can remove the clot and we can see the perforators, and I can feel more comfortable. So if I can do both, then I like clipping, but I also need to speak with the patients. So some elderly patient, of course, don't have to go through the craniotomy, then we can just coil it. But for the younger patients, I do feel more comfortable in clipping.
Thank you very much. Yes, my dear co-host Liu Bun Singh.
Yeah, thanks, Raja. Thanks, Professor, for very nice talk. Just two short question, Professor, regarding the concept about vasovasorum causing a formation of aneurysm. Would you think is by concept, is it still a good way to treat intraluminally by endovascular, and you think that any innovation can happen for that? And my second question, Professor, regarding trapping of aneurysm, where you can use both methods, especially when you have passed the BOT, balloon occlusion test, doesn't need any bypasses. So again, which are your preferred choice? Either you will go for surgically or endovascular?
For the second question, well, for me personally, I usually do not do any balloon occlusion test, because if we think it necessary, then we should do the bypass, because it's much safer than doing nothing. And sorry, I couldn't understand the first question. It was a little bit disconnected.
Yeah, the first question about now the evidence about vasovasarum causing the aneurysm formation, and do you think that the current endovascular technique or device are tackling the issue? Thank you, Professor.
Well, thank you for the question. For the vasovasarum issue, well, in terms of that, of course, I believe that clipping is better. But for the endovascular treatment, again, the devices are evolving very rapidly. So the next generation of the devices will, I believe, solve that issue.
Thank you.
Thank you very much. I think it's time to conclude. We can hear the concluding remarks from Professor Vieira.
So I just would like to thank you and congratulate again Dr. Inouye for the wonderful presentation. I think, open cerebrovascular neurosurgery will still remain necessary. Unfortunately, it will be only for those complex cases, and I would like to encourage residents and young neurosurgeons to follow this path, to learn open cerebrovascular neurosurgery, even if you want also to do endovascular, but as Dr. Inouye, learn and practice open cerebrovascular surgery because it is still necessary. So thank you again for the invitation, and it was a pleasure to be here today.
Thank you very much. It was indeed a great pleasure to watch these wonderful techniques. Thank you, my dear friend Yasu and Professor Vieira, for this beautiful session. So I'll wind this up officially. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kaito, I would like to thank both the speakers of today, Professor Virendra Sinha and Professor Yasuaki Inouye, and the chairs, Professor Maximilian Matron and Professor Eduardo Vieira, for the time and support for the ACNS webinars. Thanks to all our elite panelists who joined us today. A special thanks to Professor Mathuria. A special thanks to Professor Shubin as well for broadcasting today's webinar on WeChat channel. And as of now, we have more than 1,300 participants who are live to watch this wonderful webinar. A special thanks to my co-host Liu Bun Seng from Malaysia for joining in today. So until we all meet on the coming Saturday, it is bye-bye from all of us. Thank you very much for joining.